Okay, thank you. So now let me just a second, okay. Okay. So Rennin angiotensin system is in basically it is a kidney related system. Okay, so Rennin basically it is an enzyme that is produced in the kidneys. Okay, so we are talking about hypertension. What is the relation between kidneys and hypertension? Anybody knows that? Huh? Is there anybody who can answer me that? No? Okay, one thing you need to understand. Huh?
Sodium level can cause hypotension, and that is related to the reabsorption.
Yes. So one thing is sure that the sodium level in our body is always proportional to the stiffness of your blood vessels. Okay. So if the sodium level is too high, then the stiffness of your blood vessels becomes too rigid, and it is not able to contract and dilate as it should. So the BP will overall, if it is not able to dilate properly, and then constriction will cause raised BP. Okay, that is one of the manifestations you can see. But what about kidney? Why it is we are talking about kidney is because kidney needs BP. Okay, pressure. Why? Kidney is a filter. If you want to filter something out, even if you want to, if you have a home filter with those candles in it, then the water flows down through the filter. Why? Because gravity is pulling it, so it has some pressure, so that it will get inside the filtering substance or filter paper or filter candle, and then it will go out of the outlet, and it will block all those particles, that whatever is needed to block. Okay, so that is directly proportional. The BP, the pressure of the blood that goes inside the kidneys is very important, very essential to have its good function. Okay, if the BP pressure, afferent pressure is low, then the kidney will not be able to filter it adequately, and that is the reason that it needs to monitor. Okay, you can see the kidney is attached to this big aorta and this vena cava, I think. So so it will get directly from the central veins and arteries. It will get the blood from central vein, and then it will detect the BP pressure. Okay, if it detects that the BP is too low for it to filter, then it will try to increase the BP. Okay, it has a certain mechanism for that. I'll tell you in a minute what is the mechanism for increasing and decreasing BP that the kidney performs. Okay, so the kidney has a system. It was anciently known, it was long back known that kidneys have somehow regulates the BP, but they didn't know what exactly is that, what is the mechanism, how it does it. Okay, so early human beings, what did they do is they they try to take juice out of it. Okay, in the early days of medicine, most of the juices coming from these organs like thyroid gland and T3, T4, and corticosteroid from the adrenal glands, Okay, they used to extract those by crossing these organs. When the person is dead, they will cross the organ, and then they will squeeze out the liquid inside and then test it. Okay, when they tested this, the juice of this kidney, they found that it increases BP in animals. Okay, so they said that okay, this is the kidney produces a certain juice that will increase the BP, and this understanding remained for very long years. For I think 20-30 years it remained, and then they didn't isolate what exactly is doing that, but what they did is just like naming. Uh, Nomenclature was very harmonious at that time. Okay, something related to renal. Okay, Rennin. Why did they say Rennin? Because Rennin was derived after crossing kidney. So the liquid that is kidney produced is Rennin produces is Rennin. Okay, they named it like that, and then it was thought that Rennin is the active substance which will increase the BP, though it was not really understood how Rennin also increases the BP. Okay, so it produced, but in 1940s it was found that Rennin was in fact an enzyme, so they had no direct action. Okay, so that Rennin they called, that isolated, is basically not an active substance, it's just an catalyst. Okay, so then they found another substance which was able to constrict the blood vessel and increase the BP. That was the substance called angiotensin. So now angiotensin, please remember this name. And this topic we are discussing is renin angiotensin. So renin and angiotensin are very closely related. And angiotensin, by the name itself, you should never forget that angiotensin. What do you mean by that? Angio is something related to blood vessels. Okay, and tensin is something that will tense it up. That means angiotensin, which will tense up the blood vessels or contract the blood vessels. So the name itself gives you that it is a very potent vasoconstrictor. Okay, vasoconstrictor. And I hope from your previous classes you should be very familiar with that. If you constrict your blood vessels, then BP will increase. Why BP will increase? Because it needs more pressure for example, if you squeeze a pipe, you have connected a water pipe from a hose, from a tap, and then if you try to squeeze the pipe out, then the pressure inside the flow of the water will increase. The pressure speed of the flow will increase, no? So now that is how you increase the BP in our system. If you squeeze the blood vessel, BP will increase. Okay. And another thing, and how does it produce this angiotensin and renin? Renin is basically an enzyme that will activate angiotensin. Okay, angiotensin remains inactive form, and when renin is released, renin is the one that will activate angiotensin, and angiotensin will increase our BP. Okay, so whenever our kidney determines that the BP is not enough for filtration, it will do these things. Okay, so how does it do it? If I hope you have heard about juxtaglomerular apparatus. Juxtaglomerular apparatus is this junction here. If you see my cursor over there, I am showing you the point over there. This corpuscle is the red Bowman's capsule, and then from there you are seeing all this proximal convoluted tubule, loop of Henle, and then just before ending this nephron in collecting duct, it will slightly touch its own corpuscle. This is Bowman's capsule. Okay, so here this connection point is called juxtaglomerular apparatus. Why? Here what happens is that I will have the detailed photo. Okay, this is the detailed magnified photograph. You can see this is a thick ascending limb of Henle, and this limb of Henle is very close to its own Bowman's capsule. Okay, And then in that ascending limb, you can see that there is a macula densa over there. Macula densa is the area where it detects the sodium level. Okay, sodium level, and then gives the information to this Bowman's capsule, and this will basically activate, or if the sodium level is too low. If the sodium level is too low, then it implies that the filtration is not appropriate. The filtration is not sufficient. Okay, so if the filtration is not sufficient, then not enough salt will be filtered out. So this will catch it out. Okay, now this glomerulus will find out that this apparatus is not sufficiently filtered out this sodium. So what I need to do is I need to inform this renin producing cells called granular cells, which are just below that. You can see I am showing you this in my photograph. This is renin producing cells, which will produce cells renin after confirming the information from this juxtaglomerular apparatus. Okay, and renin is synthesized, stored, and secreted in the granular juxtaglomerular apparatus, and they will get released from there. Then what happens is that renin will activate this angiotensin. So now what is angiotensin? Angiotensin, initially it was only one angiotensin. They thought that this angiotensin is one substance. Yes, basically it is one substance, but it has many variants. Okay, and now they are known as angiotensin 1, 2, 3. Okay, so angiotensin, they started giving it. They said that this is activated by renin, and now the previously thought angiotensin was found to be again inactive. Okay, so that was inactive one was named as angiotensin 1, and then it was found that angiotensin 1, when needed, will be changed into angiotensin 2, and angiotensin 2 is the active one. Okay, so angiotensin 1 is decapeptide. It has 10 peptides, and 2 of them will be cleaved out by renin. Okay, 2 of them, and there will be octapeptide, 8 peptides together in angiotensin 2. And angiotensin 2 is the one which is responsible for contraction of blood vessels, which will increase the BP. Okay, so again I am telling you why you need to increase the BP, because the kidney is now detecting that your BP or the pressure is not very good. That is why your filtration is not very good. Now the filtration. If you increase this, then the filtration will go up. Okay. So if you try to complete that cycle, RAS system, that is renin angiotensin system, angiotensin will get converted into angiotensin 1. Okay, and angiotensin 1 will get converted to angiotensin 2. Okay, angiotensin angiotensinogen. Angiotensinogen is in the blood vessels. Okay, and by the help of renin, angiotensinogen is converted into angiotensin 1. Okay, angiotensin 1 is further converted, and angiotensin 1 also it is not active. Okay, guys, I just told you that. And angiotensin 1, later on it was found that even angiotensin needs to get converted into something else, which is angiotensin 2, and which is done by a special enzyme. It was not renin anymore, and that enzyme was called angiotensin converting enzyme. So name is easy, it will convert the angiotensin. Okay, angiotensin converting enzyme. Guys, are you listening to me?
Yes, sir.
Yes, sir.
Yes, sir.
I hope you are understanding.
Yes, sir.
Okay.
Yes, sir.
Understanding.
Okay. So it gets converted into angiotensin 2 by this ACE inhibitor, ACE enzyme. Okay, guys, which ACE enzyme. And another thing, it's not very related to this angiotensin system, but I want to mention it anyhow, because this will, I'll tell you, I told you about this, because this is one of the adverse effects of ACE inhibitors. So I want to mention it right now so that you will correlate this thing later on. Okay. So there is another system not related to BP. Yes, bradykinin. This is bradykinin is a neurotransmitter. It is a mediator. Okay. It is an allergic mediator. Okay, guys. So it can produce allergic reactions, and it is there ubiquitous everywhere in our body. So, and that bradykinin is produced regularly, and then it is destroyed regularly also. Okay? So, how it is destroyed, and the significance here is that it is also destroyed with the same ACE enzyme. Okay, so that ACE enzyme is common within both these cases. So one is this pressure thing. Bradykinin not only is an mediator for allergic reactions, it is a vasodilator. Okay, vasodilator means it will dilate the blood vessels. Like unlike angiotensin is a vasoconstrictor. So bradykinin is an inflammatory mediator. So all inflammatory mediators need to vasodilate so that it will deliver the blood into the affected area. So see, these mediators always will have they will make the blood vessel wall semi-permeable. Okay, and these inflammatory mediators. What else do they do? They will dilate the blood vessels, and they will create some histaminic substance that will create all this inflammation. Okay, and this one, if it is bradykinin is in large amount, there will be adverse effects. For example, coughing, allergic reactions will be there, and that doesn't happen because ACE inhibitor regularly breaks down bradykinin into inactive metabolites. Okay, guys. So just remember this picture. I will explain it in the later coming slides where the drugs will work. Okay. So further metabolism, not very important in pharmacological point of view, but further metabolism of angiotensin 2 is there, angiotensin 3 and 4. Okay, angiotensin 3 is not as active as angiotensin 2 as a vasoconstrictor, but it has some properties of angiotensin 2. For example, one of the properties of angiotensin 2 is it is an aldosterone secretion enhancer. And angiotensin 3 also does the same thing. And aldosterone is mineralocorticoid. Hey guys, I'll tell you about this in the coming slides. But angiotensin 3 will not have any potent vasoconstrictive action, but just it will just work as action on as aldosterone secretion only. Okay, and then it will further divide into inactive fragments, which will be filtered out. Okay, this is the whole cycle of this angiotensin system. So angiotensin 2 receptor, how does it work? Okay, receptor. It works via the receptor. Angiotensin 2 will activate the angiotensin receptor. Okay, angiotensin receptor, if it directly constricts the smooth muscle in your blood vessels. Okay, this is a very important thing. It doesn't need any mediators or anything. Angiotensin directly goes to the smooth muscles of the blood vessels, and then it will contract those things. Okay, and indirectly it can even release noradrenaline. Okay, from the adrenal glands, it can release noradrenaline. Not from adrenal glands, from the synaptic clefts, noradrenaline, which will further give that vasoconstrictor reaction, and then because of this continuous high or raised BP, it can create hypertrophy. Okay, hypertrophy, and then matrix production. Hypertrophy. Why the heart is being hypertrophied? Hypertrophy means it becomes bigger. Okay, why it's getting bigger because if you overuse something, it becomes bigger. For example, these bodybuilder people, they go and train themselves, their muscles, and then they will make their muscles seem bigger. Okay, why? Because they will have enlarged muscular fibers and everything. Okay, so same thing happens here in the heart muscles when it needs to pump quite hard. Since BP increased, vasoconstriction happened, then your heart needs to pump more vigorously, more forcefully, in order to pass the blood from in those constricted blood vessels. Okay, guys. So for that, there will be cardiac hypertrophy. Okay, this is also very important because later on I'll tell you that how it prevents, ACE inhibitors prevents this hypertrophy of your heart as well. Okay, so this is very important point. And the third one is salt retention. Why? Because it increases the aldosterone secretion. Okay, aldosterone, you know by now that it's a mineralocorticoid hormone, which will enhance the salt retention. It will increase reabsorption from sodium chloride from the kidney, and it will decrease the filtration of increase the tubular sodium reabsorption from the kidney. That is the job of aldosterone. It is always monitoring the level of sodium chloride electrolytes in the body. Aldosterone. Okay. So this angiotensin receptor will again increase this aldosterone secretion. It will try to reabsorb sodium back so that the PP will keep on increasing. All this is aiming to increase the BP so that your kidney is now thinking that the kidney is detecting BP is less. Now it tries to increase the BP. Okay. So what is that enzyme that converts angiotensin 2 into angiotensin 1 into angiotensin 2? Okay, enzyme present mainly on luminal surface of vascular endothelial cells, especially in the lungs. So though angiotensin and renin, they are related to kidney, it will be converted into angiotensin 2, where basically in the lungs. Okay. And this angiotensin enzyme will rapidly convert angiotensin 1 into angiotensin 2. You know that, identical to kinase 2, which inactivate bradykinin and other protein vasodilators. I just told you about this. So now this is just physiology. Now I'm going to talk about what are the inhibitors. We are talking about inhibitors of the system, so that we can use these inhibitors of the system as antihypertensive drug. Okay, so renin angiotensin system. First thing, how we can block this system is we can block renin, isn't it? So renin is the one which starts all the process. Okay, though it is not active, it's just an enzyme. It will convert angiotensinogen into angiotensin 1. Okay. So if it doesn't happen, then nothing of the following cascade of events will happen. Okay, that means if you block this renin, then you will be effectively decreasing the BP. So yes, that is possible. There is a drug called aldosterone, which will decrease the renin activity. Okay, that can be done. And another is that it can be beta blocker itself will decrease the renin release. So beta blocker, apart from giving you bradycardia and decreased ability to pump the blood, it will also inhibit the renin release, which will contribute it in its action on reducing your BP. Okay. Second one is aldosterone. Third one is ACE inhibitor, very important drug. Okay, ACE inhibitor. And another one, the last but not the least, is angiotensin type 2 AT receptor blocker, or ARBs. Okay, guys, angiotensin receptor blockers. Okay, one is ACE inhibitors, which will prevent the angiotensin 2 from forming, and another one is ARB. So there might be angiotensin 2 around, but since the receptor is blocked, again the same function comes. So there will be no vasoconstriction. That means there will be vasodilatation. When it is blocking everything here, leads to vasodilatation, which will lead to a reduced BP. Okay, guys, vasodilatation. So the first we are talking about not ARBs, we will be talking about ACE inhibitors. Okay, angiotensin converting enzyme inhibitors. So the examples of these drugs are captopril, enalapril, lisinopril, ramipril, and most of the other drugs which will end with pril. Okay, so it's not a rule, guys. You don't ask me or others question, this is pril, why is it in from other drugs? And that may happen, other groups. Okay, that may happen, but it is not a rule. But till now, most of the drugs are rhyming. So inhibit ACE, which lead to inhibition of angiotensin 2 formation. All have the same indication, adverse effects and contraindication, because all of them are the same. Only pharmacokinetic properties like absorption and excretion that may differ. Okay, they differ in potency and pharmacokinetics. So that was the thing. So this figure I am showing you again. Why? Because I am to show you this. that this is the blockade. And not only that, you can see the AC inhibitor that will degrade bradykinin is also blocked. So why I am again showing you this bradykinin thing is that, so angiotensin converting enzyme, in addition to its prime action, that is blocking the angiotensin 2 to be formed, they will prevent bradykinin to degrade into its inactive metabolites. That means it will increase the concentration of bradykinin in your body. That may give a bad adverse effect. That is allergic conditions that will be manifested as severe coughing, okay, dry cough, severe coughing. And most of the people sometimes dry cough and some few cough episodes might be there, but in some cases it is very severe, and which might even lead to necessity of cancelling this drug for those patients. Okay, so this, with this diagram you can see the mechanism of action of its therapeutic action and mechanism of its adverse effect. Okay, how the adverse effect comes, you can see this. So you don't forget that AC inhibitors, the adverse effect is dry cough. Okay, dry cough, vigorous dry cough, which may sometimes you need to cancel the drug for the patient. Okay, angiotensin converting enzyme, what are the actions they have? Okay, AC inhibitors will lower the BP by reducing peripheral vascular resistance. What do you mean by this? You should understand from the previous classes. What is the resistance? Vascular resistance is that if your blood vessel is dilated, then you can easily pump blood from that blood vessels. So it is known to have less resistance. It doesn't resist too much. Okay, so peripheral vascular resistance is low when you have vasodilatation. Okay, when you have vasoconstriction, the same thing that from the opposite direction happens, that you will increase the peripheral vascular resistance. Your blood vessels will resist the amount of blood that will flow inside it. Okay, so for if this is PVR is decreased, when the vasodilatation is done, then your BP will go down. Okay, no significant change in heart rate and cardiac output. Heart rate doesn't, some changes in cardiac output will be there because of vasodilatation, but heart rate will not change. Okay, and because the heart rate is not changing at all, tachycardia is not happening, it is suitable for ischemic heart disease patients. Okay guys, so why I'm telling you this is most of the antihypertensive drugs, they will have reflex tachycardia. Okay, just like alpha antagonists, what do they have? They will block the alpha receptor, they will create vasodilatation, because alpha receptors will cause vasoconstriction, isn't it? So alpha blockers will cause vasodilatation, and because of sudden decrease of BP, your body will try to compensate that. Okay, why the BP is getting low? I need to increase the BP. For that, it will reflexly start your tachycardia. You start beating heart rate faster and faster. That is called reflex tachycardia. And since this is not happening with this patient, with this drug is very good for the patients who are suffering from these sort of heart diseases, especially if it is ischemic heart disease, where you cannot afford the heart to make it contract faster, because ischemic means the heart is suffering from ischemia. The amount of blood in the heart is not adequate. That means if you keep on increasing the heart rate, the demand for the heart for consumption of oxygen will increase. Okay, if that happens, then there will be pain syndrome, which is called MI is the one of the form of that. Okay, we'll talk about these drugs, these diseases later on. Fall is small in normotensive and patient consuming normal salt, but more in hypertension and patient consuming more salt. Okay, so this drug is quite good because normotensive peoples, they don't tend to get hypotension, but hypertensive patients, since this angiotensin works because of this renin angiotensin system work, because of its detection of sodium level, it is highly dependent on sodium levels, right guys? So in normal tension people, the sodium level is always low, so it is not activated too much. So even blocking it is not a problem, because it is not in its active most form. It is not very active, so blocking it will give less change. But in hypertensive patient, there is this sodium level is increased up, it goes up. At that time, if you take angiotensin converting enzyme, the efficacy, the BP reduces quite okay, quite fast. Okay. So another thing I just repeating very much is that it is caused the accumulation of bradykinin, and which is responsible for dry cough and angioedema in susceptible. Angioedema is swelling of arms and swelling of your body because of edematous condition of your connective tissue under your skin. Okay, and that might be basically it is hereditary disease as well. But in some cases angioedema is there with calcium channel blockers, and in some cases AC inhibitors. If not properly handled, this might mm, uh, make this drug not appropriate for some patient. Another one is anti-aldosterone action that I told you in the previous slide. Is anti-aldosterone action helps you to slow down the cardiac remodeling. Okay, remodeling is modeling again. That is the hypertension, hypertrophied heart. Okay, I just told you before that because of the increased load to the heart, since it needs to pump harshly, if it needs to increase the BP, your cardiac muscles will need to work harder. Because they work harder, they will increase in size. Okay, hypertrophied. So that thing is aldosterone is one of the deciding factors that will create the matrix inside the cells, so that it will become bigger. Okay, so that thing can be slowed down. Okay, that can be hindered, or you can slow down the process of remodeling by the use of angiotensin converting enzyme. So I'll tell you that this drug is good for hypertrophies, BP, decreasing your BP, as well as it will produce protection against this hypertrophy of your heart. Okay, this is very positive point for most of the patients, because eventually hypertensive patient will have remodeling of the heart, or cardiomegaly. Okay, so it will improve intrarenal hemodynamics. Okay, since it will dilate the renal arteries as well. So dilating renal arterial means it will your kidney will receive much more amount of blood, and also reduce the intraglomerular capillary pressure. Okay, so since all the all these efferent and arterioles more than afferent arterioles dilates the efferent arteriole more than the afferent, that means the one which is taking away the blood from kidney is more dilated. That means the pressure will slightly diminish all over the kidney, which has a more protective type of function in the kidney. That is why AC inhibitors are also known as renal protective drugs. So why renal protective? Because they will reduce the overall intraglomerular capillary pressure in the blood, in the kidneys. Okay, so that will prevent further damage to the basal membrane in the kidneys, so that it will prevent formation of kidney failure. Okay, so it will diminish proteinuria and stabilize the renal function, useful in patients with chronic kidney disease, but contraindicated in bilateral renal artery stenosis. Guys, why do you think this is the case? Anybody can answer me? Okay, why is this angiotensin converting enzyme, AC inhibitor drugs, is contraindicated in bilateral renal artery stenosis? I'll tell you about renal artery stenosis, and it is contraction or obstruction of renal artery that goes into the kidney. And I might remember you. I'll try to remind you that the word bilateral. Okay, it is not a single kidney. It is bilateral. I mean to say both the kidneys. Okay, both the kidneys over here you can see bilateral. So why? Again, I want to remind you that your kidney will detect the BP, and according to that it will release the renin system, isn't it? So if there is bilateral blockade of artery before it enters the renal system or the kidneys, that means it it will receive, the kidneys will receive the reduced flow of the blood. Okay, as soon as the kidney receives the reduced flow of the blood, it will detect that the BP is now low. Why? Because it is receiving a very less amount of blood. It decides that the BP is too low, but in fact BP is not low. BP is okay, but because of this bilateral contraction or this uh, uh, stenosis of bilateral arteries of the kidney, adequate amount of blood doesn't reach the kidney. Okay, so that your kidney will think that now the BP is low, that is why I'm receiving this much of blood, so I need to start this renal angiotensin system activated. Okay, I need to get this activated, so it will start the renin angiotensin system in high activity. And then what happens? If it happens, if the renin angiotensin system will increase, then there will be very potent vasoconstriction and the BP will shoot out. Okay, so that is the contraindication. If you think that the BP is you have found a patient who is suffering from hypertension and you didn't check anything, you didn't check the renal artery perfusion and renal function test of the patient, but what you did is you just gave it to a person who was suffering from bilateral renal stenosis. Now, if you give this drug to that patient, then the pressure of this patient will shoot up. Okay, so this is one contraindication. Remember it forever. Okay, even in your clinical practice, when you go to higher classes and when you become doctor, this thing you should always remind yourself before starting any ACE inhibitor. So uses, angiotensin converting enzyme uses. Obviously, since we are talking about hypertension right now, it is one is hypertension. You can see hypertension over here. Okay, hypertension. Now, congestive heart failure. What is congestive heart failure? CHF. It is inability of your heart to pump adequate. Okay, your pumping capacity is not adequate, so that the blood is not reaching every nook and corner of your body. That is the function of a heart. Heart needs to pump the blood so that the blood reaches every corner of your body. Now this is not happening. Why? Because of some reasons you have that thing. And what does it do in this case? Angiotensin converting enzyme ACE inhibitors are the very good drug for congestive heart failure, because they will vasodilate and then make the heart easy, make the work of the heart easy to pump blood inside the arteries. Okay. Following myocardial infarction, we'll talk about that as well, especially if there is ventricular dysfunction. Why? Because again, it will reduce the cardiac output load for the heart, and myocardial infarction is the situation where your heart is not able to pump the blood effectively. And diabetic nephropathy. Okay, again, I was telling you about this protection of this nephron, isn't it? By reducing the capillary blood pressure of the renal capillary blood pressure, it has some renoprotective actions, I told you, and that can be used in this diabetic nephropathy. You know that one of the consequences of diabetes is nephropathy or renal function deterioration. So to prevent that, you can use ACE inhibitor to slow down the process of renal function damaging. Okay, and progressive renal insufficiency in case of scleroderma. Scleroderma is a systemic disease. One of the manifestations is in the kidney, so it is named as scleroderma. But it helps, but it affects internal organs as well, including this kidney. And in this case, you can use in case of scleroderma, you can use ACE inhibitors. So adverse effects, guys, adverse effects we have already learned. Adverse effect, one of them is very important we have learned is dry cough. Number one is dry cough. You can see dry is why I kept it in the top is that I was telling about this when I was talking about mechanism of action of this drug. Okay, what is the mechanism of action of this drug? Is that it is I told you while I showed you the mechanism of action, it is able to degrade bradykinin, isn't it? So now you are blocking this enzyme that degrades bradykinin. That will give you the give you this dry cough thing. I was talking about this whole class today. Okay, so you should understand that this is very important thing. Okay, hypotension, more in the fast dose, started with low dose at bedtime. Hypotension means it has sometimes, it might, I told you, though I told you that in normotensive patient the BP might not go too low, but in some cases BP might go low. Okay, especially if you are giving this drug for the first time to the patient. So if you are giving it the first time to the patient, you should keep in mind, you should start with low dose because there might be hypotension in the patient. And to prevent hypotension, you should start with low dose and then you keep on increasing slowly if you need it. Okay, hyperkalemia. Yes, this is this ACE inhibitor drugs will prevent potassium from getting out of his kidneys, which will accumulate potassium in the blood, which has so many adverse effects. Okay, angioedema, I told you about swelling of these limbs, and even in some cases inside your mouth and in your throat, and sometimes your arms, ankles, fingers. Okay, another one is petropathic. That means that it has a teratogenic activity. So in the later half of pregnancy, you should never use the ACE inhibitors. Otherwise, it will give some malformations in the fetus. Okay. So acute renal failure is used in bilateral, acute renal failure if used in bilateral renal artery stenosis, rarely proteinuria. So what this means is you can use in acute renal failure. Okay, since I told you that this has some properties of protection of the kidneys and glomerular apparatus, you can use it in renal failure, but you should make it sure that it is not bilateral. Okay, artery stenosis. Okay, if that happens, then the function may not work at all. Okay, so contraindication is both of them I just discussed is bilateral renal artery stenosis and pregnancy. So till this information I'm going to give you the information. I'm going to teach you till this information. From now I have slides of individual drugs, like I'm starting with captopril and then enalapril and other drugs. So we'll discuss that later on the next class. I think it's our next class is on Sunday. So we'll do that on Sunday. Okay, for today I've tried to explain you how this, I've tried to cover some biochemistry, I've tried to cover some physiology as well. And mind you that I didn't explain everything about it in physiology, like physiologist department of physiology would do, but I have concentrated in whatever is needed in pharmacology. So if you have any questions, guys, you can ask. Any questions? No? Am I online?
No, sir.
No.
Yes,
Yes,
sir,
sir.
you are online.
Oh, okay. So nobody answered. I thought I'm just talking to the computer. It is very, it's not very fun to teach, to shout in front of a computer. Na? I'm waiting for you guys to come here and to rejoin our, resume our teaching learning activities in the college. So So anyways, do you have any questions? Anything you didn't understand in this class?
Sir,
Ah,
so dry cough is because bradykinin is formed or it is inhibited?
it is formed. Bradykinin is not inhibited. If bradykinin is inhibited, then there will be no cough because bradykinin is the inflammatory mediator. What happens is that bradykinin doesn't get chance to get degraded. Okay, bradykinin is degraded by ACE enzyme. Okay, angiotensin converting enzyme. It converts bradykinin into its inactive metabolite. Now, what we are doing with ACE inhibitors is we are blocking that enzyme. No? So blocking ACE inhibitors will prevent formation of angiotensin 2 as well as it will prevent the breakdown of bradykinin. So there will be accumulated bradykinin in your blood, which will increase the instances of allergic reactions, including in this case dry cough. You understood?
Yes, sir. Thank you.
Okay. So on Sunday we'll be back with this topic again. Till then, you guys are free to go. Bye bye.
Thank you, sir.
Thank you,
Okay,
sir.
guys. Thank